Great. I think we have everyone now. Welcome, everyone. For those of you who don't know, this is Cindy Colson. She is the Injury Prevention Education Outreach Coordinator for the Trauma and Burn Surgery down in the emergency department. She's also one of the former transport paramedics. She is a nurse and actually recently got her DNP, so she is now officially Dr. Cindy Colson. So she'll be doing a lecture for us on non-accidental trauma and how it relates to the transport environment. So Cindy, go ahead and take it away.
Hey guys, thank you so much for hanging out with me here on what is it? Is it Wednesday night at 5 p.m.? I would much rather this be a conversation, so please feel free to interrupt me, unmute yourselves, and if I say anything that would not ever work in transport, or if I say something that's completely off base, please let me know. We're all here and we can all learn from each other, and I'm just going to do the best that I can. You're going to see me try to stick on this side of the screen because I have this weird dot that turns part of my face black. So if you see me leaning, that's why. So briefly, we're just going to go over tonight about what we can do about identifying abuse, reporting abuse, and a little bit about preventing abuse. Because part of my job at Children's is injury prevention, and I feel like we have to talk a little bit about that as well. At the beginning, I'm just going to share with you some statistics from the National Child Maltreatment Report. So this report comes out every year, and yes, I know this says 2021, but this is the most up-to-date version. You can get this online. It's over 300 pages long. If you wanted something for easy reading, it's free to download. You can get the PDF, and it will give you all of the stats that you ever wanted to know about child maltreatment. So I'm just going to go through some of the highlights of it, just to kind of give you what it looks like in the nation, not just DC, but not the overall. So first, in defining what is maltreatment and abuse. So it's defined as when someone, whether through action or failing to act, causes injury, death, emotional harm, or risk of serious harm to a child. And this maltreatment report breaks up the different definitions of child maltreatment into neglect, physical abuse, sexual abuse, sex trafficking, and then other. And other is the category when there's multiple types of abuse, torture, I mean, you name it, it's in that other category. One thing that I wanted to definitely make and distinguish is what is neglect and what isn't. So when we think of neglect, it's failure to provide housing, food, any of the normal things. But if a family is experiencing homelessness, that is not considered neglect. It's considered neglect when you're not providing a home for your child because you spent all of your money on drug use. So I just want to make sure that everybody does know that is not considered neglect. Poverty is not neglect. Some risk factors that are listed in the National Child Maltreatment Report are alcohol abuse by the caregiver, domestic violence, drug abuse, financial problems, inadequate housing, public assistance, or any caregiver disability. Now, with those being said, if a family is experiencing one or all of these things, it doesn't mean that their child is going to be maltreated. It just is a risk factor, and that makes the chances of abuse or maltreatment happening in the home all that much higher. So when we look at kids and we look at different demographics of kids, and right now we're going to particularly talk about ages, is there a certain age group that you think is more at risk or not at risk at all? When we're talking about babies, toddlers, school age, adolescent? One not at all, one more than the other?
I'm going to say 1 to 3 years old.
As more? Okay, I'll take that as a more. So absolutely, the younger kids are most vulnerable. So these, and this is a graph that was taken directly from that report. And if you look at kids that are under 1, they are the most vulnerable. And then when you look at all of the rest of the ages, every single age is vulnerable to abuse, but the highest amount are children under 1. And that makes sense. Kids under 1, they can't really communicate their needs. They can't run. They can't say no. They can't say stop. They can't tell somebody something bad is happening to me. So this makes sense to me that the victims of maltreatment and the most vulnerable are children under 1. And just as Amy had said, like kids under 3, that's where the bulk of abuse is happening. Just some more stats on that. So over 580,000 children were victims of child abuse and neglect in 2021. More than 1/4 of the victims were, birth to 2. And then the victimization rate is the highest for, children that are under 1. I think the next question that we all want to know is who's doing this? And, this, when we were looking at the perpetrators, just in DC versus the perpetrators nationally, being on transport and being in the PICU, I always thought it was the boyfriend. Okay, somebody was abused, it was definitely the boyfriend. But when we look at the national data, 90% of victims are maltreated by one or both parents. And, that statistic was pretty staggering to me, especially when I thought about, 2020, during COVID, what was the one thing that everybody kept on saying to everyone? You're safer at home, you're safer at home, stay at home, you're safer at home. But then when I look at the perpetrators of child maltreatment and find that it's one or both of the parents, 90% of the time, those kids weren't safer at home. And, that really gave me cause to really sit back and reflect of, the whole world is saying this, but for some kids that just wasn't the case. And then, so I broke this down a little bit into a graph. I thought that would make it look a little bit a little easier. So you can see the mother is the highest relationship as a perpetrator. Second is the father. And then third are 2 parents of known sex. When we're talking about non-parents, this kind of really goes through the gamut, but the highest for non-parents are relatives, and then that unmarried partner or unmarried partner of the parent. So, and again, this is national, this isn't DC data, this is national. But when you look at all of the perpetrators that are on this list of people that have been defined as causing maltreatment to children, you look at all these things and it's who's safe? And it's really, there's a lot of bad people out there. So with all of that being said, and now we just kind of have an idea of what the numbers look like nationally, I think the question that we're all really asking is how do we identify non-accidental trauma? And that answer is what you do every single day, every single time that you take care of a child. Assessment, assessment, assessment. Some red flags that, some quick red flags that are helpful to keep in the back of your mind to raise that index of suspicion are 3 or more ER visits. Now, when you go out to an outside hospital, are you necessarily going to know if they had 3 or more visits? Probably not. But likely that outside hospital will know if that child has been there multiple times. If any of you have ever worked in the ER, and I do know that a couple of you have, we all know that if we are going to take care of a kid, we're going to look up and see how many times they had been there. And most health records are able to do that, especially in emergency rooms. The next thing is the history inconsistent? The next is the history in the exam inconsistent? So is the history that they gave you, does that make sense? Does the history match the assessment that you got? Was there a delay in presentation? And some people say, well, I'm not an expert at knowing whether an injury is old or new. Well, that's just not true. You are experts. All of you have been at Children's for more than a minute, and you know what an old injury looks like, and you know what a new injury looks like. You can tell when something has not been looked at for a while, especially if it's a wound. Any fracture or head injury in children under 1, and also bruising in non-mobile children. So those are the big red flags that most of you probably already knew. One of the things that I would like to talk about is bruising. So bruising is the earliest and most common form of physical child abuse. It's the most easily recognized sign of child abuse. And unfortunately, it's the most common direct sign of physical abuse to be missed. Because, as providers, I feel we all have that, we don't ever want to think about a child getting abused, and we always want to make an excuse of okay, well, this bruise happened because, a light fell on him or a toy fell on the child. And we truly do want to believe that the people taking care of the children that we're going to take care of aren't lying to us. We don't so many providers just kind of like try to think their way around it. But when we see bruises in the very young, we need to just really look and see like, how did that happen? So there was an article published in, well, that says 199. So this is 1999. And this was like normal bruising in infants and toddlers. So normal bruising is very, very small until we get to the age to 12 to 14 months. So what happens at the age of 12 to 14 months with kids?
They start walking.
Right. They start toddling, they start pulling themselves up, they start cruising, they start running into things. And look at when they're almost 3. I mean, that's like, if your 3-year-old doesn't have a bunch of bruises on them, that would also be surprising. So when we're seeing bruising in children, particularly under that 4-month mark, that's when we are like, how is this really happening? Because it is so rare for a child to have a bruise at that age, because they just aren't moving that much. Next, I have a list of the random things that I have heard while working at children's for histories for infants with bruising. He laid on something. She must have fallen against the side of the crib. The cat must have been in the crib. His brother probably did it. Oh, she hits herself in the face. It happens all the time. Or a toy fell on him. Has anybody else heard an interesting story for bruising that just didn't really make sense? Amy, I know you have a few.
The non-mobile kids that fall off the bed.
Right, right, exactly. So when we talk about bruising, there's an acronym that I found like really helpful called the 10-4 bruising model. So TEN-4, so it's an acronym. We all love acronyms, right? So TEN, so this is torso, ears, and neck. If you have bruising in those areas, and if the child is under 4, or if there's more than 4 bruises in the very young, or any bruising on an infant under 4 months of age, that is sensitive and specific for inflicted injury. So in the torso, so think about the torso. There's a lot of cushion in that area to absorb forces. Direct abdominal blows can actually cause injury with minimal external bruising. We don't really see a lot of bruising to the stomach and that whole area. The ears, our ears aren't very vascular at all. They're quite difficult to bruise. And the neck, I mean, and think about kids and their necks. Like these kids have giant heads, the body doesn't even catch up to the head until they're like 8 years old. So the neck is relatively protected by the shoulders with short falls and rarely has bruising. So if there are bruising to the TEN region, so that's the torso, the ears, and the neck, and children under 4, or for the number 4 can also be more than 4 bruises in the very young, or any bruising on an infant under 4 months of age, those are highly specific for inflicted injuries. A few years after this study came out with to verify and quantify like how sensitive and how specific this was, they added some more. So they added the word faces to the second part of it. So faces stands for frenulum tears, auricular area, cheek, eyelid, and sclera. So when I say frenulum tears, what am I talking about?
Like that under the lip from force feeding.
Absolutely. So when you're looking, so we there's a frenulum above your teeth, below your on this gum line, and then also under the tongue. So anytime that one of these is like ripped or torn, there is concern that there could be, as Josh said, like forced feeding. Now, can you tear your frenulum other ways? Yes. But does it happen in a very young infant on accident? Not that often. And again, so the 10-4 faces is a really like helpful thing that you can apply in your mind to every single child that you are taking care of. And that could be like a helpful thing of like, I'm concerned the story doesn't match. Do they meet the 10-4 criteria? It's just like little tools that you can keep in your pocket and in your mind anytime that you're assessing any child, no matter what it's for, whether it's like for a stubbed toe, whether it's for asthma, whether it's for a broken femur. these are things that it's always good to kind of run through your mind every time you're taking care of any child, because just because they're in there for asthma, it doesn't mean that something else isn't happening. I sound like I've been at Children's for a minute because like I feel like I run through these things whenever I take care of any child. So next we're going to go through 3 different case studies of different cases that we have seen here, and kind of like the outcomes, and I hope that you guys will talk about this with me. So we'll start out with 5-month-old Bethany. She went to an outside hospital with 4 days of not moving her right arm, and she had some swelling. So before the kiddo got to the outside hospital, mom called 911 because Bethany wasn't moving her left arm, and she noted some bruising. The ER said, you know, when we looked back at the chart, she was seen the previous week for a bleeding lesion under her tongue, and labs were drawn to have her worked up for like a bleeding disorder, and Bethany was sent home because she did not have any of those issues. And then they said she has a bucket handle fracture of her distal humerus. So before you get to the hospital, you have all of that information. Is there anything that you would want to ask either the parent or the outside hospital? Like, what questions would you be thinking about? No questions?
The mechanism of injury.
Okay, great. Right. Like, how did she, like, why isn't her arm moving? So when you get to the hospital, of course, you know, you split up, you and your, you know, medic goes one way, the nurse goes the other way. So the parent is telling one of you, the mom is angry. She is like, I want to get out of this hospital. The care at this hospital has been terrible, and she wants to leave. Then she says the ER held her down really roughly to get blood, and that when they were in the ambulance, that her baby bumped her arm because they weren't careful. And then your other counterpart is getting a report from the outside hospital saying that the swelling occurred 4 days after that blood draw. So when mom was being upset about the blood draw, that was when she was there previously to with the bleeding lesion in her mouth. They're saying that the swelling occurred after that. They're showing you that there's a bucket handle fracture of the distal humerus, and that they want to send this child to Children's National for a possible OR and a non-accidental trauma evaluation. So I am not a radiologist, but this is the x-ray. We call it the positive arrow sign. So here's the arrow, and like right here, this little shadow. Can everybody see that? That would be the bucket handle fracture. And a little bit about bucket handle fractures. So it's a specific characteristic of inflicted injury. So it's related to the shearing forces generated by like rapid acceleration, deceleration, or torsion. So that's when a child's arm is yanked or twisted and pulled. And that is very indicative of like non-accidental trauma. So when you see a bucket handle fracture, like that really should like go off in your mind. So a little bit about what happened with Bethany. So ortho reviewed the films. There was concern for a more extensive fracture that needed reducing in the OR. She also got an NAT workup and a CAPC consult. So CAPC is our Child and Adolescent Protection Center that's in our hospital. We have 3 physicians that are specifically trained on child abuse and like ruling abuse out. So that's really their main job, is to look at injuries and the history and all of the things to really make this decision of like, could have this happened accidentally? Could have it not? Like, and kind of ruling all of those things out. Not only do they do all of that like history and physical, but they also go to court and testify on behalf of these children. At Children's National, our non-accidental trauma workup, any child that is under like 2 years old or under, they get a skeletal survey. So that is a picture of every single bone in the body. That is not a baby gram. We have outside hospitals that get so excited because they're like, we did everything. We even got a baby gram. And we're like, that's great, but we're going to do it all again. But, you know, we smile and we say, thank you so much. Even knowing that we're going to have to be doing all of these x-rays once they get to Children's. Any 1-year-old or any age with altered mental status will get a head CT and a D-dimer. We do abdominal CTs if there's elevated transaminase levels or any evidence of abdominal trauma. And again, having evidence of abdominal trauma doesn't happen that often because in that torso region, you can absorb a lot of energy without having outward signs of injury. Of course, we'll do a CBC, BMP, amylase, lipase, ALT, AST, UA, UTOX, all of the things. And then even further down the line, we'll do osteogenesis and perfecta labs, blood disorder labs. We always try to get those pre-transfusion. So if you have a really sick kid that's going to need a blood transfusion, we always try to send those before. But again, like in a crisis situation where you have a kiddo circling the drain, I understand how this doesn't happen all of the time, but it is something to think about that if you could get those labs like at least pulled before giving blood, it's just something to think of in the back of your head. So what happened to
Cindy.
Bethany? Yeah.
So one time at an outside hospital, they were giving blood, and I asked them to go and pull the tubes that had been sent to the lab, and I brought the tubes back. And I honestly never knew if our lab accepted those. Would that happen if they were labeled properly? Is that something that CAPC would appreciate or not appreciate, or would it be useless?
So that's a really good question. And when things come from the outside hospital and if the tubes aren't the same, I don't know if our lab would accept them. But if they would, I feel like CAPC would be 100%, 100% appreciative. But that is a good question. And, you know, I will have to follow up with the lab to see if they would do that. I know that like every hospital has like has the different blood tubes. And I
Right.
don't like, and also like how long have they sat out, and like, does it have to be refrigerated? Does it not? But that is a good question. And I think it would be most pertinent for everybody on transport because you would have the opportunity to make that difference. But I'll definitely, I'll find out from the lab.
I look forward to your response.
I look forward to finding out too, because I mean, that's a good question. And I have no idea. I mean, like if we put a sticker on backwards, sometimes they won't take it. So,
Hey, Cindy,
yeah.
what color tube would that be if we ever had the opportunity to take one with us?
For OI and blood disorder labs, I don't know.
Okay.
But yeah, I don't know what color. But it's easy to find out. So if you go into into Cerner and you go into it's like the third or fourth tab in the middle and drop it down. There's a lab tab, and then you can just type in the type of lab and it'll tell you exactly what color tube. But those are, yeah, you could bring the tubes with you, but I do not know off the top of my head what color. Amy, do you know? Or Heather, do you guys know what color OI or blood disorder labs go in?
I absolutely don't.
Yeah, it's definitely something that we don't do all that often, and I would always have to like look it up underneath that lab tab in Cerner.
Yep, lab tab was what.
Yeah, that is very helpful. But I'll definitely find out if our lab would take other tubes. And I wouldn't even want to say I'll definitely find out what color tube OI and blood disorder labs go in, because I feel like sometimes we change things so often that looking it up for like those very like low volume, high acuity cases, it's better to look it up the day of, because we do change products so often. I mean, I feel like every other day we are getting an email of like, don't use this tube, use that tube, or we changed vendors. So I feel like the safest way would either be to look on that lab tab or call the lab before you leave or on the way. So for Bethany, her skeletal survey was negative. Her head CT was negative. It was confirmed abuse, and she was placed into foster care. So that's like a really quick, easy, simple thing. So confirmed abuse doesn't happen often. Confirmed abuse only happens like quick and easy if the perpetrator said, yes, I did this. That does not happen often. So this was wrapped up with a nice, like, quick bow. But to get confirmed abuse, most of it is like includes like home visits, CPS involvement, forensic interviews, police involvement, a lot of different things to get to where this is. But in this case, the parent did say, I did this, and Bethany was placed into foster care until the mother was able to get to a place where she was able to take care of her child safely. So the red flags for this case. So she had swelling and bruising occurring 4 days after an IV placement. That is not, does that seem like a plausible story at all? Yeah, no.
Nope.
There was, so she had an injury after an ambulance ride, also does not make any sense. This is a non-mobile child with a fracture. She had an ER visit for a bleeding mouth. I put non-mobile child with fracture on there twice. Apparently, I feel like that's very important. And when Capsy went further into the medical record, she also had a primary care appointment visit for a bleeding mouth a couple weeks before that. So there were signs that were missed before she got that bucket handle fracture. So she had so now she had one visit to the primary care for a bleeding mouth and an ER visit for a bleeding mouth. And then she came in with a fracture. So a lot of frenulum injuries, a lot of people who don't deal with kids all that often just do not see that as like a sign of abuse, but all of you guys do. Any questions on this kiddo before we move on to the next one? Okay. So this is a 21-month-old boy, David. The story was that he fell into a bathtub. So his background was no prior medical history. So the boyfriend called 911 because David fell into a bathtub. David's mom was at a mandatory meeting for the housing program. So David was in care of the boyfriend and 2 additional siblings at home. So that is all you really heard. None of the you know how sometimes you kind of get a little bit of a story, but you really have no idea what's going on until you actually get to the outside hospital. Well, this unfortunately was one of those days. So once you get to the hospital, this David, after falling into the bathtub, has a 40% TBSA partial thickness burns with clear demarcations between the burns, no splash patterns to the chest, back, arms, left leg, entire GU, and buttocks, and he's waiting on a head CT. So they kind of meet you at the door before you see the kid, and they say, okay, we're waiting on a head CT. Here's what we see. And then when you go to the bedside to do your physical exam, you do see the burns, but then you also see linear ecchymosis to the anterior neck. You see ecchymosis to the left cheek, the left ear, the left eyelid, and the upper frenulum is torn. How are we feeling?
10-4.
Oh, right. That's a pretty bad bathtub. And then the head CT revealed a subdural bleed. So again, I am not a radiologist, but this does have the positive arrow sign. So here are the arrows. And then you can see along the sides, subdural and subdural. So does your assessment match the report you got? What about this additional bruising? If you wouldn't have done your really good assessment, you would have missed the neck and the cheek. Sometimes, especially, I feel like so often we try to talk ourselves out of is this really abuse? Is this not? I mean, obviously not in this case. I mean, this is pretty blatant and really bad. But one thing that can happen, even if you're working with somebody who has a lot more experience with you, just because somebody that you are working with doesn't have a concern and you do, that doesn't mean that you're wrong. So if you use the same methodology for every single patient, every single time, no matter what it is, and go through does this match? Does this history match the exam? Go through your 10-4 faces, and then just go through that every single time. That's probably the best way to keep kids safe and not to miss anything. So the final disposition of what happened with David, his final injuries were he had an immersion scald burn, his subdural hematomas, he had a grade 4 liver lac. Now, again, he had burns in a lot of places. So plus that was, that's the torso. So there wasn't any bruising, but if there was bruising, more than likely you wouldn't see it if the burn was over it. Unfortunately, that is something that we have seen quite a few times at Children's when children are abused, that sometimes they'll be burned to try to cover up a potential bruise. He had healing, an 8th rib healing fracture, an acute 9th rib fracture, a subacute left femur fracture that just means that it was an old fracture. And he ended up going to rehab and doing very well, and the boyfriend was placed into police custody. That didn't happen right away. That happened after a lot of work went in by law enforcement, forensic interviewers, and CPS. So red flags for David's case is there was no there were clear demarcations and no splash patterns on the burns. His upper frenulum was torn. David was a little bit older. So what did we say? He was 21 months old. So that's a little old for having a frenulum tear. So that might not be from force feeding. That could be from a direct blow to the mouth. The story was inconsistent with the injuries, and he had linear ecchymosis to his anterior neck, which, is choking. Any thoughts on this kiddo before we move to the third case study? Amy or Heather, do you guys remember either one of these kiddos?
I don't.
I don't either.
Okay, and then we have our third case. So this is Sarah. So you are going to go pick up Sarah because she has vomiting and right-sided abdominal pain. How many times do you go pick up a 10-year-old with vomiting and right-sided abdominal pain? Like quite a few, right? So your history is that she's been vomiting for 3 days and she has right-sided abdominal pain. So when we think that, what do we think? Like, what's on our differential for a 10-year-old with right-sided abdominal pain and vomiting?
Happy.
Happy.
Right, 100%. So appy, gastro, maybe an ovarian cyst, maybe she's pregnant. I know she's 10, but these are the days we're living in. Constipation, I feel like the number one thing is we're all thinking appendicitis. So you get all this, then you get there and you get a whole bunch of information from mom at the bedside. So she's like, Sarah falls a lot. Sarah has a history of microcephaly at birth because from a result of a chlamydia exposure, and mom's a talker. She's telling you all the things. She has cerebellar hypoplasia. She has bilateral neurosensory hearing loss, and she has ataxia. So she falls a lot because of her microcephaly and her cerebellar hyperplasia and all of her other issues. She was a known patient to EMS and the hospital. She had been hospitalized multiple times for intracranial hemorrhages in the past from falls because, again, even though she had microcephaly, she's the head is still the lead point. So when you're falling, she's hitting her head. And her most recent fall resulted in an intracranial hemorrhage and a skull fracture, and that was about a month prior. So when you are in the back of the ambulance and you decide you're going to log on and kind of look and see wow, this kid's been here a few times, what's going on, find out that she's been worked up by neuro and multiple services. It's been noted in the chart multiple times that mom is really frustrated of why they can't prevent Sarah from falling because it's all of these admissions. And there is a plan in place from the last neuro note to get a more detailed workup to make sure that Sarah isn't having subclinical seizures, and that's why she's falling a lot. So a little bit about Sarah overall. So she functions at a 2nd grade level. So she's 10 and she's functioning at 2nd grade level. She's enrolled in a charter school in DC. She gets services. So she gets OT and PT 3 times a week each as part of her IEP. And mom had called 911 before the hospital with a complaint of vomiting, right side abdominal pain, and with no history of trauma. So you're bouncing around in the back of the ambulance and you're looking through the labs and you see a lipase of over 4,700 and an amylase over 800. And they did, the head CT did not have a hemorrhage, and they just went ahead and ordered it, even though she was only complaining of belly pain and vomiting. They just did a head CT anyway because she was vomiting. So how do we feel about the lipase and the amylase? What's a normal lipase?
Three digits, I know that.
Right, yeah, so small. Normal lipase is like 10 to 140, and a normal amylase is like 40 to 140. So these are crazy high numbers. So we take her to the ER. So you're bouncing down the road and you're like, oh, amylase lipase. And like you note that it has like the little arrow that has the elevated sign, but and then when you can see like what do they give you the value, like the normal values, like right next to it in most of the documentation. You're like, wow, those are really high. You're probably like, oh, something must be going on with her pancreas. Maybe that's why she's having all this pain. Maybe it isn't her appendix. Maybe it's her pancreas. So you get to the ER and they do a complete, you're back at Children's, and they do a complete ultrasound of the appendix. So, which is normal because we're all thinking appendicitis. The ultrasound shows abnormal enlargement and decreased echogenicity of the pancreas, and it's compatible with pancreatitis. And her amylase is like elevated, her lipase is elevated. So she's diagnosed with pancreatitis with unknown etiology. Okay, so then she's admitted to the hospital. And any thoughts before we go on to her hospital stay? Okay, I just think it's a really interesting case. Yeah,
Did she have a good belly exam and LFTs and all that other fun stuff too?
yeah, nothing crazy.
I know for
Nothing-
adults, usually pancreatitis is secondary from like alcoholism, but these kids don't drink, and it's usually secondary from some sort of previous trauma, right?
It can be, and sometimes, and she's not a normal kid, so that kind of throws everybody off, because sometimes kids with like all like these medically complex kids get like weird things, so we just really don't know. But in a normal kid that has like all of those, yeah, you would probably think some type of injury, but she had no history of it, just had history of vomiting and pain, and she's functioning at a second grade level, so she should be able to tell us like if something else was going on, if she felt comfortable, because she is functioning at a second grade level. So anyway, she was admitted to the hospital with a surgical consult for that pancreatitis. And then she said that she fell about a day ago from a kitchen chair, and no bruising was noted to her abdomen. So belly was soft and flat, not distended, and no bruising. But she continued to have, complain about a lot of abdominal pain. And she did say that she fell from a kitchen chair like 24 hours previously. So they did an abdominal CT the next day because she continued talking about all the pain. Anybody want to guess what they found on the CT? And Josh, you can't answer because you've seen the slides.
Kind of bleed.
Either a splenic or a liver lac.
And Caitlin, were you going to say something?
I'm just saying some kind of bleed or something.
So lo and behold, she had a transected pancreas, rib fractures, acute and healing, and a possible pelvic fracture. Imagine everybody's surprise when they looked at that CT. So she then bought herself a CAPC consult and an NAT workup. So again, I'm not a radiologist, but positive arrow sign. So this is the abdomen, this is the spine, kidney. This right here, this thing that kind of looks like a sausage, that's the pancreas. And see that spot right there, that is a transection of the pancreas. So that's a complete transection. And it's a pretty decent sized one. Like if you it's not easy to get a good image of what a transected pancreas looks like.
So that takes significant force because there's no hard structures around that to
100%.
have that bounce off of.
Yes. So that is literally my next slide. Like, how does one actually transect a pancreas? Because it's really hard to do. It's like less than 2% of blunt trauma injuries, and it takes, Amy, exactly what you were saying, excessive force. So it's like one of those organs that's like really protected. It like sits high up in the retroperitoneum, and it is only sudden localized force to the upper abdomen that compresses the pancreas against the vertebral column. So if you think of this is the vertebral column, and then this is the pancreas, it like squishes it up against the column to make that transection. So we don't see that often, but when we do, it's normally from like a steering wheel till the chest or the abdomen. So we see that in adults like way more than we do in children, obviously. But we do see it in kids every once in a while with a handlebar injury. So if they're riding their bike and they, fly over the handlebars and the handlebars like go into their gut, that can push the pancreas up against that vertebral column and transect it. But can this really happen from a short fall? No, it cannot. So the team went even further back into her chart to kind of look and see like what else was going on, because that is part of the CAPC medical reviews, to kind of look at all of the records like in the recent future. I mean, in recent future, how am I doing? The recent past, to see what else was going on. So she was seen 1 week ago by nutrition because she was failure to thrive on a regular diet. She was seen a month before for a fall, a month before for an optho consult, 2 months ago from an ED fall from a bunk bed, 9 months with just a regular neurology follow-up, a year ago for a fall, 4 years ago for like a foot injury with like a weird method, 5 years ago for a hand burn with like with a delay in treatment. She had 4 previous CPS reports filed with no current CPS involvement, and 2 CPS reports initiated on medical evaluations in the ER. So that means somebody from the outside called something in, and then that made CPS bring her into the emergency department for a medical evaluation.
Cindy, quick question on the records review. Is it just you type their name in CRISP and see where they've been? If it's not a Maryland, do you go to other hospitals to get those records, and do they cooperate with you, or do you need paperwork to assume them?
So all of these for this case were just being seen at our hospital. So often when they're doing like a deep dive on a patient to like try to figure out the full story, they'll often go to the pediatrician. And from what I have understood, it's not a difficult situation trying to get information for these cases. Sometimes it does take a court order and some law, but everything ends up coming out.
And your CAPC docs will work with the state's attorney's office to get those if needed?
100%.
Okay, being nosy, thanks.
Yeah. So Sarah ended up having on further assessment, and this was after, so she had been in the hospital, had all of the things done, had been assessed, got that CT, they did the transected pancreas, and then when the CAPC docs came in and did their assessment, they found left ear bruising. And that was one thing that was an outward thing that nobody even saw. Nobody saw ear bruising on this kiddo until CAPC went in. But this is a kid that they're thinking like pancreatitis or appendicitis or some weird thing. Totally missed the ear bruising. That's an ear bruise is may not seem like a big deal in a 10-year-old, but it is. So she had left acute, subacute left-sided rib fractures in different stages of healing that transected pancreas. So she had signs of acute and chronic abuse. She was discharged to inpatient rehab, and her parents were, at that point, were only allowed to have supervised visits. Now, Sarah's tricky because, sorry, my phone was going off. I apologize. So she had multiple visits that for her, and she was tricky, but she had multiple visits and her injuries didn't match the story. But she's also a 10-year-old functioning at a 2nd grade level. She has a medical history that can explain falls. And, she was seen by so many people in the system. I mean, she was getting special services at her school, like OT and PT 3 times a week each. She was being worked up by our nutrition. She saw our ophthalmology. I mean, CPS had been involved in her case multiple times. And she's one of those really vulnerable kids. Yes, she isn't under 1, but she is not functioning at the same level as a regular 10-year-old. And this is one of those things where assessment. It doesn't matter what the presenting condition is, doing the same thing every time can really help. Any thoughts on Sarah? And I've made up all of the names and some of the things. So
Cindy, what was the mechanism that caused this, or was it a series of mechanisms that caused this?
no one ever said anything. So we really don't know how, what type of blow, like what type of blunt force trauma hit her in the abdomen.
I've seen that before. It was a baseball bat.
Yeah, people do terrible things. But yeah, nobody ever said exactly like how it happened. It was still just, oh, I don't know how that happened. Oh, she must have fallen. But again, even if you fell like directly on a chair, like in a kitchen, like you're not going to transect your pancreas.
Right.
So I'm going to talk a little bit, and this is like one thing that I am not an expert at, but I've done a lot of reading on it because I had a lot of questions. And it's about reporting and what does that mean? And I feel like that might be helpful for everybody on transport, because I always I questioned about like, what does that mean? And what do I need to say? And what do I not need to say? And all of that. So, the next part, this is just about reporting. So, in 2019, professionals submitted like 68.6% of reports, alleging child abuse and neglect. So professional, basically, if you have a job that you're working with children, you're a professional. Non-professionals are like friends and neighbors and relatives. And then I have some lovely pictures of mandated reporters. Yay. Okay. So when you're thinking about mandated reporting, does this mean like talking to your team about the concerns? Just telling the ER when you drop the kid off that you're concerned? Finding the social worker in the ER and telling them you're concerned, documenting your objective findings in the electronic health record, or and reporting to CPS. Like, what is actually, like, when we say mandated reporting, what does that mean?
So I have run into this. I had spoken to the in-house social worker, and she had me call the CPS of the county where it occurred. So she said it is my responsibility as the person reporting to have the direct contact with the county where the incident had occurred, and that there's no kind of escalation through her, but she would help you facilitate that conversation.
Okay. And did you call on a patient that you're picking up from an outside hospital?
Correct.
And did they tell you they called?
No.
Okay. So mandated reporting is pretty much exactly what Josh just said, is actually making the report. So telling a social worker you have concerns is not enough. Talking to your team is not enough. But the most important thing, because I understand the time that it takes to make a report. So you need to make sure that someone has made the report. So if the outside hospital says that they made the report, you got to find it in there that like somebody actually did make the report. Now, I will say it's always better to make a report yourself as well, because if the outside hospital made a report and then you made a report and then the ER social worker made a report and then the CAPC physician made a report, now that's 4 on 1, and that can actually make it more of like a case. And every jurisdiction opens a CPS case for, like, they all have different criteria. I don't know the criteria, and I don't know it for every single jurisdictions, but if you know that somebody made a report, as long as somebody has made a report, that is really where it is. So Josh, I'm glad that you called, because you were not, like, you as a mandated reporter you weren't covered if the outside hospital didn't make the report, but you have to be able to prove that somebody did make a report. So some quick definitions about like mandated reporting. So I'm not going to read these all out to you, but basically if you see something, say something, and you have to have reasonable cause. And so Josh, you've made a report. Amy or Heather, have either one of you like actually had to call and make a report?
A few when I worked in the ED in Florida.
Okay. Amy?
I have multiple times.
Okay.
But in different places that I've worked. And I will tell you, I have more angst doing it here than anywhere else, because every other place that I've worked, I just pick up the phone and call whatever the jurisdiction is. Here, it always seems like if I was going to make a direct notification, I was stepping on somebody's toes. Because I've at one point in time mentioned something to an emergency room physician here who said, no, I don't think so, and was going to let it drop. So I made a contact myself, but it still felt like I was stepping on toes and politically improper, but I was going to err on the side of the kid.
Well, Amy, of course, I mean, you did the right thing and you taught me to do the right thing. So I'm glad you called anyway. I mean, like, I don't care about anybody's feelings. Like, if you're concerned that a patient is being abused, like, make the report. But for anybody on the call who hasn't had to make the report, I will say it can be a little overwhelming and it's not quick. So I just wanted to like quickly run through what they'll ask you, because I think that if I would have known that, it would have helped me. Just knowing at least what to expect. So number one, it's not quick. It's not like I have concerns about this kid. Okay, I gotta run. They're going to ask you questions you're not going to be able to answer, and that's okay. It is okay if you do not have all of the answers to the questions, but this is a list of the questions that they'll ask you. So they're going to ask you for a full name, date of birth, address, and the address of where the alleged incident happened. Chances are you're not going to have all of that information. Then they're going to ask for the parent or guardian's full name. They're going to ask if the alleged perpetrator lives with the child. And again, you might not know all of these answers, but they will still ask you. They will still go down this list. And again, it is okay if you don't know the answers. Of course, number 5, I think this is the biggie, like a statement of the child's disclosure and context of the disclosure, if a disclosure was made. And number 6, like, why are you calling? Like, why do you think that the child is being abused, neglected, or maltreated? Like, what's the purpose of the call? And like, I hate that that's kind of like further down on the list, because it can be overwhelming to make this call and you just want to get it out and you have to like go through all these like ridiculous demographics before you get to like the meat and the crux of why you're calling. But I think just knowing that that doesn't come off right off the bat, like you have to get through the other things that could possibly get you flustered, like keep on going. You're going to get through the demographics before you can get to number 6. And then also like they will ask you who you are and what you do, and a statement of actions taken by you and other staff concerning the child. So this is when you would say, you know, I'm a nurse or a paramedic that works at Children's. I transported them from like X to Z. X made a report. I've put it in my note that I'm making a report. I'm concerned for these reasons. And so it's not anonymous. They will ask you for your name and what you do. So what does this mean for you? So CFSA is not required by law to disclose the name of the reporter to the family. But this does not apply to the police. So as a reporter of a child abuse and neglect, you may be called to testify. So all of these things may happen. The chances of them happening are small, but I don't want to be like, you can do things anonymous. Nobody will ever know. Like, this is like, yeah, you may have to go to court. Likely, probably not, because that's why we have an amazing like CAPC section in our hospital. They're the ones that go and advocate for these kids. But your name will not be hidden from the police. Like, they will know. The responsibility to report suspected child maltreatment definitely outweighs any confidentiality requirements. Like, it's way more important to keep kids safe than to, not let your name get out there. Sometimes parents are going to try to guess who made the call to the hotline. And, based on some of the information regarding specific allegations, they might be able to identify exactly who called and when. But the investigator is never allowed to reveal your name or any identifying information to the family. So they can't be like, oh, they work at Children's, or, oh, they were on the transport team. That will never happen. But I think
Cindy, I have made notification and requested to be made anonymous. I was on a neighbor and requested to be anonymous, and they did not have me give my name.
From my understanding, if you're a mandated reporter, so a professional, they will ask. But if you're just a neighbor, I don't think they will allow it to be anonymous.
Okay. Yeah, I didn't know the designation. All right.
Yeah,
Okay.
I feel like that's the difference. I may be wrong, but I'm pretty sure that that's the difference between like, yes, you are a professional, but you're not like a professional neighbor.
Cindy, I have a quick question.
Yeah,
Again, I'm a medic, so I've seen a lot of these by myself.
yeah.
I've run into this where the outside hospitals nurse said, we have concerns for NAT. I just wanted to let you know so you can file the report, quote unquote. What do we do in that case where, I mean, it's obviously a ton of paperwork and some time consuming stuff that's have to be taken care of. Do we tell them that they're the first caregivers, they have to make the report, or do we just take it back to the ED and let the docs know that, there was suspicion on both sides? And when you're a medic out on a call by yourself, how do we take care of that?
So in your most PC way possible,
Go ahead.
like again, because I understand the politics of the bear. In the most PC way possible, you would say if you have a concern for abuse, you have to make the report, even if, and you can say, I'm going to make a report, but you need to also, like, it's very important that you call and make the report yourself. I will too, but we like that jurisdiction needs to see the other people, that like it wasn't just one person that was concerned.
Okay.
And yeah, in the most PC way possible, tell them they need to call.
Understood.
Not to interrupt, but as the intake nurse, if they tell me that, I tell them that. I say that it has to be filed in the county, that they're concerned for the incident or where it was initially reported, and that if they have concern for abuse, they have to report the abuse, and that we will take care of it at Children's when we get there as well, because I can't remember the exact call that this happened that I learned that, but now I try to make it a habit to do that so that our medics don't run into that situation.
Yeah, because it definitely, when you don't have a partner out there and you're just like in the wild, wild west wearing the bear on your shirt and you're like, no, you have to do this. It's a lonely road sometimes. So I'm really glad that you asked that question. And Lakin, am I saying your name correctly?
Yes, that's okay.
Yes. Yes.
Okay. I'm so glad to hear that you're telling the outside hospitals like that they need to make the report. Like, that's amazing. And it's exactly what needs to happen.
Cool. Thank you.
So all of this information about mandated reporting and all of the questions and answers, because there's a lot more information on this. So I'm going to take this and I will put it in the chat. You can actually take a mandated reporter training. It really isn't that long, and you can log in and like save your progress, and it really gets into the nitty gritty of all of this. I guess I'll do it once I'm done at the end and I'll put it in there, but it's free. It's through DC. So this is DC. This is CFSA through DC, not Maryland, not Virginia, but I feel like this will it kind of gives you a really good overview of like really what are the definitions. And I found it really interesting because I am really not good talking about something unless I really understand it. But I feel that like as a medic, for as long as I was a medic before I was a nurse, I was terrified to make a report. And for the longest time, like in the 911, not at Children's, but in the 911 system, I thought if I told the bedside nurse that I had a concern, that was reporting. I was like, they'll do it. I don't have to worry about it. And even as an EMT basic, like talk about like being out there. So once I really came to the understanding of really what is mandated reporting, and it's not just making sure that somebody else did it, I found that really helpful, and I thought that it might help somebody else, which is why I kind of went into this whole like mandated reporting thing. So with that being said, like, why do we miss abuse? Because this happens. Not just with like, I would say it doesn't happen as frequently in a children's hospital, because I feel like we are like keen on some of those subtle details like bruising to the ears and frenulum tears and all of those things. But, some of our outside hospitals and, people who don't deal with kids all the time and people who deal with kids all the time, they're just unable to recognize abusive injuries. They just can't they're uncertain that if abuse really occurred. They already have a good relationship with the family and are afraid of the family's reaction. Lack of time So if you think about like the last time you went to your primary care provider and like how many patients you saw in the waiting room, there's also like a concern with the legal system. A lot of people don't want their name out there. You know, when you aren't looking for bruising near the ear, you know, when we're not like, when people aren't like completely undressing kids to do like that full skin assessment, like bruises can hide. As providers, a lot of times like bruising can be easily dismissed because you can think it's something else. It's not really in the differential diagnosis. We're going to like people minimize those findings, and really talk themselves out of it being, you know, whether it's abuse or not. Like people really want to talk themselves out of something being abusive. And, you know, why do you think that we miss abuse sometimes? And when I say we, like the greater we.
I think silence is really prevalent, and the ability to hide. And, you know, when it's little babies, I almost think it's almost easier to identify, because as kids get older, like even if the parents suck, they're still the only parents the kid has, right? And they're still very dependent on them, and they still love them, and they still want to protect them. And in many cases, it's like, if you tell, you'll be taken away.
Right.
And the unknown is even scarier than the bad known that they have now made sort of normal, like it's become normal to them. I was actually going to ask you in all of the statistics, because of that, right? We obviously don't know a lot of what abuse goes on. Is there any sort of estimate for how much we miss?
So not in the National Child Maltreatment Report, but there have been studies done that show us that some kids are suspected less than others. So kids with private health insurance and that are white, they are suspected less than others. And then some kids are reported more than others. So kids with lower like when they, like kids in poverty or Black and brown children are reported way more than other children. So, you know, some kids are suspected less, some kids are reported more. And, you know, when like when we put in biases by what a child looks like, or whether they have private insurance, or what their parents do, when we're like, oh, their parents are a doctor and a lawyer, there's no way that they could abuse their kid. Like we have to do the same thing every single time, no matter what. Ask the questions like, do the injuries match the story? You know, does it do these injuries match the development of the child? Like, is there a pattern of injuries? Like, did they hit the 10-4 faces like thing? Like, apply the same rules of assessment to every single kid, no matter who the patient is, no matter who the parents are. You don't ever want your, like, our own biases to overtake like a knowledge gap. Like, we have to do it the same time every single time, and ask yourself the same question every single time of, are you concerned? And if you're concerned, why are you concerned? And do it the same way for every single kid. And were there red flags? And that, I mean, that is that.